Welcome to the Cass Health Podcast, the show where we hope to connect our community with healthcare information that's relatable, understandable, and useful to your life, and where you get to know better the neighbors providing your care here. I'm your host, Ann Mukherjee, and in today's episode, we're talking with pulmonologist Dr. Sumit Mukherjee about lung cancer. Before we get started, two quick disclaimers. First, the comments in this podcast do not necessarily reflect the views of Cass Health. Second, the information in this podcast is not intended to be construed as personal medical advice. Always consult your primary care provider with your questions and concerns regarding your health. Dr. Mukherjee, thank you so much for coming to the Cass Health Podcast.
Thanks for having me.
We are going to get started with some fun get-to-know-you questions.
Okay.
So tell us where you're from.
So I'm from Omaha, Nebraska, born and raised, and I left for a while during my training and went to med school in Omaha, but then left and moved to Houston and then Kansas City and then back to Omaha. So happy to be back in this area of the country.
Omaha's a great place to be.
Oh my gosh, it's great. Yeah, it's fantastic.
What's your go-to exercise or activity?
You know, I actually recently got into boating, and this is something that I did not grow up doing. I had no, and so not so much sailing, but just doing some boating, recreational boating, and it's been so I started this in the last 5 years or so. And I've had so much fun doing it. It's been a fun family activity. And so that's been something that I've invested a lot of time in over the last 5 years, just learning more and more about it and seeing different places. We travel kind of around the Midwest and explore different areas, down kind of Ozarks and Table Rock, and then Okoboji. We spend a fair amount of time in Okoboji now. And so that's been really fun for my family and I. And then it's just been a fun thing for me to get into and learn, about the culture and about all the things and all the toys and all the things that go along with boating. So yeah, that's been great.
And you said you have two boys, so I imagine there's some tubing or water skiing happening with the boat.
Yes, exactly. So lots of fun water sports, tubing. And so they started off zup boarding a little bit, where they kind of learned how to, it's like modified skiing, right? So it's like knee boarding, and then they learn how to stand up. And so they do some of that. That was a fun place to start. And then learning how to ski and tubing and doing all those things, lots of fun. And then wakeboarding and some of those things are a lot of fun for the boys.
It sounds like a great way to make lots of memories with the family.
Oh, absolutely. It's been some of our favorite memories for the summer. So yeah, it's been great.
Awesome. How about a favorite sports team?
So Kansas City Chiefs, living in Kansas City for 11 years. And I will say, I know there's a lot of Chiefs haters out there now, with all the runs that they had. But boy, I was living in Kansas City when the Chiefs were terrible. And as a resident, our residency class would go out and have some fun events and things at the games, and so I just have some fond memories. And so it was really nice to see Kansas City come alive when the Chiefs started being so great, and then and so I ended up really trying to go back every time for some of the games when I could. And some people in my residency and fellowship class, we just kind of made it a tradition. So hopefully that sticks.
Oh, that's so fun.
Yeah,
that's so fun.
Absolutely.
So not a fair weather fan. You've been in for the long haul.
Right. Yeah, we have been in for the long haul, but still, Kansas City sports in general. Yeah.
Okay, if you're cooking dinner to impress, what do you make?
So Indian food is something that I really enjoy, and I've really, in the last 2 to 3 years, I've really tried to kind of be a little bit more creative with cooking, and particularly Indian food, just to get back to my family roots a little bit, which is, my parents are both from India, and I was, born and raised obviously in Nebraska, but love Indian food. And so learning how to make, chicken tikka masala and, some of these dishes that, take some time to create different spices and things that I've, not been familiar with. And my kids, and my wife is not Indian, but she's just kind of learning how to do all of that. It has been pretty fun.
I love it. Sounds delicious.
Yeah, it's been great.
Driving alone in the car, which you've got a little bit of a commute out here to a clinic here. What do you listen to? What do you jam out to?
Oh my gosh. So we've had some great weather in this time of year. And with my recent love for boating, there have been, any music that will remind me of the summer and being out on the water. It has been kind of what I will listen to when the weather gets nice. But I also so that would be, there's a lot of country music in there, that comes along with being outdoors and summer and all of those things. But I really, easy listening music. So I'm a big Lumineers fan. I've been to a bunch of Lumineers concerts. We've traveled we're a little bit, like my wife and I are a little groupie here with Lumineers at this point. So we've traveled a little bit all over the country to see Lumineers, at different venues. We went to the Hollywood Bowl in California to see them and some of those other places. And so, it was a lot of
favorite
fun.
place that you've seen the Lumineers? Was it
It was the
Hollywood Bowl?
Yeah.
Okay.
Yeah. I mean, that is such an amazing venue. And so, but last summer we were in we saw them in Kansas City, and we've seen them in Omaha. And so, yeah, it's been great.
Oh, Lumineers groupies. Okay.
Yes. Yeah,
Love
absolutely.
It. Do you have a favorite holiday?
So it has slowly become more of the summer. So Memorial Day has become some of my favorite memories. A lot of that ties into what I was saying with the opening of boating season and being able to do fun summer things with my family. But I love Christmas. I love Thanksgiving. Just times with family and really kind of depends on, I do a fair amount of call and work and that type of thing. And so as you get into, the winter, so the holidays, it gets pretty busy, so I really like that downtime. And so Memorial Day has really become one of my favorites.
That's a first.
Yeah.
That's like we have 4th of July folks like me, every now and then, but Memorial Day,
Yep.
I love it.
Yep.
A favorite book or a movie?
So I would say favorite movie would be, oh boy, that's a hard one. So Garden State.
10?
So Garden State
Garden
is one of
State.
my favorite movies, and everybody thinks that's very strange. It's kind of
with Zach Braff, right?
Zach Braff,
yeah.
And Zach Braff is one of my favorites. I love everything that he's produced or directed.
And there's new Scrubs coming out.
I do. Yes, I'm very excited. In fact, some of my coworkers and I are talking about having a Scrubs, a nice
party?
watch party. Yeah.
Oh, how great!
Yeah, and then but he was also involved with Ted Lasso a little bit, which I really loved. There's a show out called Shrinking on Apple TV now with Harrison Ford.
It gets rave reviews.
Oh my gosh, it's great. Yes, and so Zach Braff's in that, so I really enjoy really anything with him. But Garden State's one of my favorite. It's just kind of, there's nothing really special about it. It's just kind of like, it's kind of funny. It's kind of dark. It's kind of, it's just, it has all the feels. I like that.
Where would you like to travel?
Oh boy. Well, my family and I are going in the spring. We're going to Spain and France, and so that's been on our bucket list for places to travel and see. I really want to go to Australia. That's been one of my it's been on my list of places to see, and we've never been. So that's, I think that would be, if I had a choice here in the next couple of years, it's on my list.
Sounds fantastic.
Yeah.
Long flights.
Yeah, long
right?
flights,
but,
yes.
But well worth it.
Yeah,
so,
for sure.
And Spain and France
yeah,
with the kids.
Yeah,
Neat.
that's going to be great. So, we have been to Madrid before, but we're spending time in Barcelona, and then we'll move over. I've not been to Paris, so we're going to take the kids and go over to Paris, and so it'll be great.
Sounds fantastic.
Yeah, for sure.
We always like to talk to our providers about why this career. Was there a moment that you knew I'm definitely going to be a doctor? Was there a moment that you knew for sure pulmonology was where you wanted to land? Tell us a little bit about your journey in your career.
My path was, so I started off as a young child thinking that I wanted to be a doctor, and some of that was just encouragement from my parents. Some of that was I had some medical issues with an uncle that I was close to growing up that kind of made me just interested in why is he sick, what's going on, and I just started reading. I remember being in like second grade or third grade and just going to the library at my elementary school and in Omaha and checking out books on the heart and looking at, and just learning about like what's actually going on there. What is the heart and the structures, and learning about all of those things. But like so many people, I kind of veered off of that path. I always knew I wanted to do something within health or medicine, but then through college, I explored things like, being a pharmacist, or potentially being, an occupational therapist. I just kind of looked through a little bit of everything within healthcare, and that's one of the great things about healthcare is that there are so many options and so many rewarding things that you can do to work with people and make a difference. And obviously, that was kind of what I was moving towards. So then I landed in this public health area where I thought, okay, I really want to try to make a difference for a large population of people. I really enjoyed research, and I really fell in love with kind of working and learning about cancer, working with people who had cancer. I thought it was pretty fascinating to read about some of the clinical trials, the medications and things like that were available. So I went to public health school at the University of Nebraska Medical Center and studied community health and epidemiology and biostatistics and research and all of those things to kind of help learn about how to do research, make big changes in populations of people, and study kind of community health and health education, how to create and implement programs to change behaviors and or make an impact in outcomes. So that was one of the most valuable experiences I've had in my educational training, because it relates so much to what I do now. So then I moved to Houston. I got a job working at MD Anderson in Houston, and that's where I fell in love with working with in the field of cancer. MD Anderson is like a city in terms of it's huge facility, right? And it's like a city in itself down in the Med Center in Houston. And my wife was going to law school in Houston at the time, and so that's really what brought me down there, and had that opportunity to work there and work in research. I worked in the phase 1 clinical trials program initially, which was looking at, we'd have these companies come in from all over the world, and it was interesting. Like, they would scour the oceans, the sea floor, and find all of these random compounds and plants and, things that they would look at and study and figure out what kind of impact these things had on cells at the cellular level. And they would start doing those phase 1 trials. And that's how things like chemotherapies are found, right? I mean, some of these things like, chemotherapy agents, they come from trees, and some of these other things that, you just find. And it's so interesting to see how this starts from the very beginning. And it's interesting to see how, patients that really have no other options for chemotherapies and treatments enroll in some of these clinical trials and have pretty dramatic responses oftentimes. Sometimes they don't, unfortunately. But that was a really interesting place to start. And then I moved more into the general internal medicine field of at MD Anderson, where I started working with side effects of chemotherapies, really trying to understand So a patient has lung cancer and they get this type of chemotherapy, and all of a sudden this whole cohort of patients starts having this side effect from chemotherapy. How do we deal with that? Are there interventions, medications, other interventions to be able to really have an impact? So I did really enjoy that, but after some time of doing research and clinical trials, and I just really missed that kind of patient interaction, the bedside, and I have always known something about myself, that I'm a hands-on person. I really love and enjoy procedural work, and so I just really wanted to be a little bit more involved. And at that point, I made the decision to go to medical school, and I wanted to do something within cancer. That was really where my drive to work with cancer came from. And so I thought I was going to do oncology going into medical school.
I mean, that was going to be my question,
Yeah.
because it sounds like, wow, you're really getting teed up here to
Yep.
go oncology, but you didn't.
I did not, no. So I think what you learn, and this is anything outside of medicine, right? I mean, what you do for your job every day, so much of it is what is my day-to-day life going to be like? I mean, not just your work hours, but the types of activities that you do. Are you going to be primarily in the office? Are you going to be sitting all day? Are you going to be moving around? Are you going to be in a dark room looking at slides all day? All those things are considerations for people who go into different fields, right? Not just medicine. So when I landed and did my rotation in oncology, I quickly discovered that so much of oncology care is outpatient. There's a lot of inpatients that have, that have cancer and that are sick and that end up in the hospital, and the oncologists follow them in the hospital. But really, when they're sick and they become very sick, being on chemotherapies, immunocompromised, and all those things, they end up in the ICU, and the critical care, and all those things. And so I kind of fell into this critical. I started getting drawn a little bit into critical care, taking care of the sickest of the sick in medical school, and I really didn't know at the end of medical school where I was going to land. I knew that I didn't want to do a lot of office-based work all the time, that I wanted to do things that were more procedural, interventional, but I also knew I wanted to continue to work with oncology, and that's a little bit of how I fell into pulmonology. But to be honest, it was the critical care aspect of pulmonology that really drew me to pulmonary and critical care medicine. Just really, really loved the taking care of the sickest of the sick people and being able to make an impact right away. And it is very procedural as well. You are working to put people on ventilators, you're putting in lines, you're doing all these things, and you just feel like you're doing something. Sometimes you feel so helpless as a doctor, where you're just like, boy, I really want this person to get better. You can take your hands and you can put them on a person, and you can just feel like you are doing something to help impact and change them. So that's really where I fell in love with pulmonary and critical care. And then because of my cancer background, I started gravitating more towards pulmonology and lung cancer specifically. And then with my public health background, I kind of just fell in love with the opportunity to focus on healthcare outcomes, education, lung cancer screening, nicotine cessation, smoking cessation, program implementation, development, and all of those things. And that's kind of how I fell into where I am. So probably a long explanation for a simple question, but
no, it's fantastic. I just love seeing how all these puzzle pieces over the years bring you to now.
Yeah.
And just make you just such a well-rounded physician, ready to tackle these big, tough questions and these terrible diagnoses too, to help people navigate them. So no, it's a fantastic answer. So we asked you to come in today to talk with us about lung cancer. We know that lung cancer is the deadliest cancer. Can you tell us more about why lung cancer is so deadly?
Lung cancer is often found late stage, and that is why it is so deadly. The lungs themselves, there's no nerve endings inside the lung tissue itself. So if you have a spot in the lung and it is enlarging, you're not going to feel it, and so it's very difficult to, and you don't feel it until it has grown to a certain size or it's pushing on a certain structure. And so that's why oftentimes lung cancers are late stage by the time they are diagnosed. And that then translates to, stage 4 disease, which has worse outcomes than early stage disease. And so that's why it is the number one cancer killer in this country and globally. More deaths annually than colon, prostate, breast combined. Really trying to make an impact on that with finding those cancers earlier. And so we'll talk about screening a little bit later, but it's certainly something that we're hoping to create some change there.
The late stage is what makes it so deadly. What is the prognosis for someone who is diagnosed with an early stage versus a late stage?
Yeah.
I imagine there's quite a big difference.
Yeah, absolutely. Significantly improved. You can look at these different prognostic indicators that will tell you different numbers. I will tell you, those are kind of just statistics, and you never really know. And with the advancements of targeted therapies and immunotherapies and all these different things have changed for later stage cancer, certainly, but molecular testing and all of these different things. But there is a significant difference between an early stage cancer, which we would classify as stage 1 and 2, or a later stage cancer, which we would classify as a stage 3 or 4. Once it gets in the lymph nodes, that's really the issue. And so, prognostically, the survival, with an early stage lung cancer is very good. You'll see different numbers across the board, and so I hate to make a single quote of what the 5-year survival would be, but generally for a stage 1 lung cancer, you still have a very, very good prognosis and potentially curable disease, and so. That's something that we really try to push for in making a stage shift where we're seeing more of these stage 1 and 2 lung cancers versus 3 and 4s.
Who's most at risk? Is there any difference between men or women or certain ages or other risk factors?
Yeah, risk factors really, men and women are both affected with lung cancer. That has shifted over time as smoking has also kind of affected. So the prevalence of smoking, first off, higher in men and then in women. And so things kind of, so you see trends in different parts of the world as it relates to men and women and lung cancer. But we do know that women tend to have worse outcomes for one reason or another when they have lung cancer. As far as the prevalence of lung cancer, largely related to smoking, but there's a large number of folks who get lung cancers who have never smoked in their lives. Up to 20% of those who have lung cancer have not smoked, or considered by criteria non-smokers. And then as we know, there's some environmental exposures, there are some genetic factors, there's a lot of other confounding variables as it relates to lung cancer. And so that's, but the things that put you at highest risk are the exposure to cigarettes.
What about symptoms? Are there symptoms? What are those symptoms?
So symptoms are, this is part of the scary part about lung cancer is sometimes when you develop symptoms, those symptoms are related to a lung cancer that has been progressing for a while and may be in the later stage. So weight loss, unintentional weight loss. You're losing weight, you can't figure out why. Sweats at night, drenching night sweats, that can be from a variety of things. Hormonal causes and things like that can also. So there's a lot of different reasons why you can have some of these symptoms. Cough, worsening cough, coughing up blood certainly is a red flag. And so some of these things, increase shortness of breath, but again, they're tough, right? There's a lot of reasons why people can have increased shortness of breath or a cough that's persistent, So it is very difficult, and oftentimes when you do develop those symptoms from a lung cancer, it can be concerning.
Is lung cancer preventable?
It is preventable to a certain extent. There are so many factors that can influence lung cancer, such as behavioral factors related to smoking, even some of these behavioral factors related to environmental causes. So actually globally, when you look at things like indoor cooking, for example, poor ventilation, you're burning wood or coal indoors and you have poor ventilation. So, globally, this is a huge issue because there are a lot of places in the world that don't have great indoor, ventilation and things like that. And so the inhalation of those materials was definitely a risk for cancer, and it's more of a risk than, let's say radon or something like that we hear about in this country and in this region, which is a risk factor for lung cancer. But certainly, in that setting, there are things you can do to try to help, with improving. So a lot of policy implementation and making sure that, like in this country, potentially for those environmental factors, you talk about air quality, you talk about radon mitigation, you talk about, some of those, again, public health kind of factors that you can really make an impact in by policy change.
I suppose you do get asked about radon by patients quite frequently, because in Iowa, we know that we have high radon numbers, and that can be part of your risk factor, increasing your risk for developing lung cancer.
Absolutely.
What if you have high radon and you're a smoker?
It's so difficult because in the areas that sometimes have higher radon, you also see higher rates of smoking. And so, and I don't know why that is exactly, but it is very difficult to have, those confounding variables, just kind of separated out so that you can say, hey, this percentage is attributed to radon and this percentage is attributed to smoking. That's tough, So we do know that certain things have a synergistic effect as it relates to lung cancer. And so when I say that, I mean just kind of combined together increases your risk substantially. And so certainly I think it's important to look at radon mitigation. The exact contribution to radon, the numbers are fairly, inconsistent and variable, but we know that it's a risk factor. We know that you should work to inspect your home, do radon mitigation, and all of those different things. And we know that you should not be smoking and doing all those other things, together to decrease your risk. But it's hard to measure, okay, well, if you live in this area with high radon and you're a smoker, if you move from that area with high radon or mitigate, is that going to decrease your percentage for lung cancer by X amount? That's hard to say.
Cancer is very complex.
It is.
And it would be so nice if it was just a simpler answer. This is the cause.
Exactly.
This is why. And you can change this one thing. Right?
Yeah.
But it doesn't work that way.
No, it doesn't. It doesn't.
So how do you identify lung cancer? Are there screenings? Are there routine screenings? Most people know about mammograms for breast cancer or colonoscopies for colorectal cancer. But lung cancer, if I'm not a smoker, it's not on my radar. If I am a smoker, should it be on my radar? Walk us through, what is screening for lung cancer?
Absolutely, yeah. Screening for lung cancer has been late to the game in terms of cancers, cancer prevention, screening for lung cancer. really came around in 2000, like kind of short, like 2005, 2010 is kind of when the thoughts were, hey, we should really look at doing these clinical trials, looking at X-rays versus CT scans for trying to find lung cancers. And so then there was the National Lung Cancer Screening Trial that was done 2011, and those types of studies, and then later followed by a study called the Nelson Trial, looked at lung cancer screening. And what I mean by lung cancer screening is you do a CAT scan of your chest. It's a low dose, they call it a low dose CT scan, which means it's a low dose of radiation. It's not a chest X-ray, but it's a CAT scan that just takes a simple snapshot of your lungs, but you're able to see the level of detail to look for spots inside the lungs. And so that's what we mean by saying lung cancer screening. And so if you do one of those CAT scans, low-dose CT scans of your lungs once a year, based on the studies that we have done, we have found that it substantially improves your ability to find lung cancers earlier and has really had an impact in that stage shift I was referring to earlier, where we're finding more and more cancers early stage rather than late stage, because again, you can't feel that spot in your lung growing. And so if you do that low dose of radiation CT scan, it will help find those cancers early. And yes, it's been late to the game, and they've made some modifications as far as who is eligible for screening as time has gone on, because they've seen the benefit. So the people that qualify for these lung cancer screening scans are people who have the highest risk. And we talked about this earlier, but age-wise, the highest risk for lung cancer is between the ages of 50 and 80. And so that is those are the ages where, and they've recently decreased that age from 55 to 50, where you're eligible to start the lung cancer screening, and then they've increased the upper limit as well over time, because we've seen the benefit to doing those screens. So if you are between those ages and you are a smoker, or you have quit within 15 years of eligibility, you are eligible to do lung cancer screening. And so, they did assign a certain amount of smoking exposure to being eligible for screening. And that's really because what we want to try to avoid are the false positives. Our lungs are just exposed to the environment. It's pretty natural that, you have some spots in your lungs. And so we don't want to have a bunch of false positives where we want to find those people who are at highest risk. And so that's why smoking history matters. But generally, if you have a 30-pack year smoking history, when we say pack years, it's a pack a day. For a year would be a pack year. So if you have 30-pack year smoking history, then you've smoked a pack a day for 30 years. If you have, or let's say you smoke 2 packs per day, but you've done so for 15 years, that would also be a 30-pack year smoking history. So we look at those pack years and the duration of smoking to really, and your age, to really determine if you're a candidate for lung cancer screening.
And sometimes calculating those pack years, that can be a little complicated. So I think the general advice there is talk to your provider.
Absolutely.
If you're going to meet that criteria.
Absolutely, you should.
If I'm a non-smoker, lung cancer screening doesn't need to be on my radar.
Correct. If you're a non-smoker, it's not necessarily that it doesn't need to be on your radar, because here's the thing. There are other factors, right? We talked about some of those other factors. Let's say you're a person who's had lung cancer, a strong family history of lung cancer. Those genetic contributions are very difficult to come up with a clear defined policy of like, hey, if you had this amount of genetic influence, how does that translate to your risk? But I have taken care of several patients who've had no smoking history and a strong family history. And so there are those types of factors. Secondhand smoke, for example. There's a lot of people who have worked in restaurants or bars and been exposed to a lot of secondhand smoke, or grew up in or live in a household where there's a lot of secondhand smoke. those people, we know that that's a risk factor. We just can't attribute how much that is a risk factor to lung cancer and make it a recommendation because, again, we're trying to rule out some of those false positives. We're trying to keep those out. So if you are somebody that feels strongly that you've had those exposures, you can still get a low-dose CT scan, and you should pay attention to those things. They just aren't implemented in the guidelines and policies. But you can come to your local lung cancer screening program and say, hey, I'm interested in doing a low-dose CT scan. And many facilities have the option of just essentially cash paying for those CT scans. And it's actually more reasonable than you'd think in terms of cost. I'm sure it's different at different facilities, but generally fairly affordable for a CT scan. So I think that is worth it for some people.
So again, if you've had some exposures over time, or if you have that family history, if you know that there's some tally marks that say I might be at risk here, talk to your provider. Doing the screening might be an option for you. It sounds like maybe not covered by insurance.
Correct.
And so it might be something you could still have the screening, but you're going to pay out of pocket for that.
Exactly.
If that CT scan does show something suspicious, what are the next steps then? How do you investigate further what that spot is?
That's always a complicated issue, and it has to do with your probability, statistics, right? So if you are somebody between those higher risk age groups, 55 and 80, 50 and 80, and you have a certain smoking history, we take those into account with kind of calculating your probability for a cancer. But it is important at that point to really look at certain radiologic characteristics of the spot. So what does the spot look like on the scan? How big is it? That's a big factor. Does it have calcifications in it? Is it nice and round and circular, or is it kind of spiky and what we'd call spiculated? Those types of things really matter in terms of the probability. So we have ways to calculate that probability and then really determine what the next steps are. And we have guidelines to help say, okay, well, if you are at X, Y, or Z risk, you should get a CT scan again to follow this spot in 3 months or 6 months or a year, whatever it might be. Sometimes people end up having additional testing done, such as maybe a different type of CT scan that can determine whether or not there's a lot of activity in that spot. Or sometimes they have a biopsy done. Sometimes they can have some blood work done that kind of helps risk stratify. So, you can say, all right, you have a 40% probability of this spot being related to a lung cancer, but if you do this blood test and it finds that you don't have X, Y, and Z marker, well, then it can drop your probability from 40% to less than 5%. So it helps kind of statistically reclassify your risk.
So is that where and I've heard, I read a lot about cancer now, and I go to a lot of meetings about cancer. So I've heard about Notify.
Yeah.
So is this what Notify does for patients?
This is what Notify does, yeah. So Notify is a blood-based test that basically works to risk reclassify, and it helps to either rule in or rule out statistically the probability for a lung cancer. So if you see a spot, spots are so common. Again, if I were to scan 100 people randomly, probably 30 to 40 of them would have little spots inside their lungs. But when they reach a certain threshold, that's kind of when you need to start thinking through, well, what else can I do to help figure out if this is a cancer or not, besides cutting it out or doing something very invasive. So Notify is one of those tests where you can do a blood-based test to say, hey, this was a 50% probability of being a lung cancer, and now it's not. Or now it, has gone from 20% to 50%, and so that is something that is really helpful for us to determine what to do with these.
And again, it's not very invasive.
Correct.
And I imagine a few days for results then?
Yeah. So
what's the timeline on that?
There's different timelines for the rule-in test versus the rule-out test. One is called an XL2 test. One is called a CDT test. The CDT test is a rule-in test. And basically what that does, and that comes back quickly. I mean, you can get the results back within really 48 hours, 72 hours. The the rule out test, maybe a little bit longer, but generally you are looking at days to be able to get this result back, and it can really help influence what the next steps are.
Fascinating.
Yeah,
Fascinating.
It's fantastic.
So cool.
Yeah.
So as a pulmonologist, you provide care to people with lung cancer routinely. What's that like for you, and what's that like for your patients?
This has been such a rewarding journey for me in working with lung cancer and people who have lung cancer, because while it is devastating to get a diagnosis of lung cancer, the time we are living in now is a time where we have made such drastic strides in lung cancer, more than we have done at any point in history, between lung cancer screening, between diagnostics, minimally invasive diagnostic modalities such as robotic bronchoscopy and some of these other things, and staging modalities, and treatment options. So the treatment options have really changed with doing biomarker testing, molecular testing, targeted therapies, all of these different options that patients have to treat their lung cancer. It has been such an incredible journey to see how medicine has been able to take care of such a devastating cancer and have improved outcomes. And so I've really enjoyed watching that process and seeing the outcomes, the improved outcomes for patients. But it can be devastating. It certainly can take a toll, and there are months where, in my office we have, we kind of have this, my nurse navigator is so kind, she has this box of cards that, she sends to our patients when we have a loss or something like that, our patients' families. And some months you burn through those pretty quickly, and it weighs heavily on us, and some of these folks we've taken care of for years and years, and it's, they become part of our family, and it's just really, it can really take a toll, and so that can be very, very challenging. But I would say, as with many things in life, it's a balance, and those great outcomes and those positive things that we see tend to outweigh some of the negative, and so it continues to be a very, very rewarding thing for us.
How do you feel about vaping? Are you worried about what the future holds in 20, 30 years for people who are vaping?
Vaping is certainly a new frontier, I think, here with all of this. And we know that, there are things like vaping associated with acute lung injury that can happen. You've heard about kind of the pneumonitis and things that people can get from vaping where they...
Is that popcorn lung?
Yeah.
Okay, I was going to say, I've heard that term before, but it's hard for me to I assume that's what the structure of it looks like. Is that why they call it popcorn lung?
Yeah, well, so popcorn lung actually is an interstitial process, which is basically meaning that it affects the tissue of the lung. And the reason they call it popcorn lung is because it was actually found in some of the flavoring of butter, like the butter flavoring for popcorn.
I didn't realize that.
Yeah. So there are some chemicals inside some of those flavoring that can cause this reaction. And so there's acetaldehyde and these other types of chemicals that we know can create these types of reactions, and that are also carcinogens. We just have not seen the true outcome with like, for example, vaping and some of the cartridges and some of the chemicals inside the cartridges and the flavorings and some of those different things, what the outcomes and in terms of cancer risk are truly going to be.
What have we not talked about that you're like, we really have to talk about this?
Yeah, so I do want to spend some time talking about, I think I mentioned this, some of the frontiers here with our progress in lung cancer as it relates to screening and therapeutics. But what I have not talked about so much is diagnostics, and that's so much of what I do as a pulmonologist and interventional pulmonary, where we are able to diagnose cancers fairly early and minimally invasive. So there is a new technology now that's available called robotic bronchoscopy. And essentially what this does is we use a robot, which is similar to, if you ever heard of like the Da Vinci robot, the Da Vinci, one of the arms of the Da Vinci robot, we can essentially use, it's called ion bronchoscopy, robotic bronchoscopy, where we are able to basically travel anywhere inside the lung from the inside with a scope, and you are sleeping during the procedure, and we can get to these spots where we never were able to do that. Historically, we would have to wait until these cancers grow and are large enough. And sometimes you just have to cut them out at that point and do a big surgery, or sometimes you try to do a biopsy and you don't get an answer, and then it just grows and grows and grows, and then there are other ways to get to these by, going through the chest wall or something like that, which has a high complication rate where you collapse lungs and you have bleeding and all these things. And the other benefit of doing robotic bronchoscopy is where you go inside the lung and you're able to get to a spot, and then you're able to diagnose the spot right then and there. Then you are able to stage that cancer. So what I would do if I found a cancer intraoperatively with a robot bronchoscopy is then sequentially stage the lymph nodes and make sure that there's no cancer inside the lymph nodes at the same time. So at the end of your procedure, you wake up, you go home, hey, I've got a lung cancer. It's an adenocarcinoma. It's negative nodal disease, so it is likely going to be a stage 1 or stage 2. You've likely already had a PET scan, so you are now all ready to go for treatment. And so those are things that we've really strived to do, is decrease that time between diagnosis and treatment. And so that's really one of our goals, is decreasing that time, because you don't want 2 months to go by while you are waiting for what to do with this lung cancer, or 3 months or 4 months. And oftentimes it's longer, as you're watching these things grow, or, whatever it is. And so pretty amazing technology that's out there. We have the ability to do 3-dimensional scans, see the tool inside the lesion as we're doing the biopsies, knowing that we are there by multiple different modalities, and being able to, in some cases, at the same time, being able to do some treatments. So
when you say some treatments, are you removing?
Those aren't being removed at the time where we're doing the biopsies. But let's say that I was doing a biopsy from the inside, and I, let's say, found that there was an obstruction somewhere with a cancer. I could potentially, at the same time, go in there and, if it was blocking, if there was tumor blocking an airway or something like that, sometimes I could go in there and just start removing some of that obstruction to help clear the airway. Sometimes we can put stents in there and just try to, open things up so that things continue to flow. So we can do that all at the same time, when we're doing the bronchoscopy from the inside. So
that's amazing.
Yeah.
And I don't think this is happening at Cass Health, so I imagine that this is happening at your other locations.
Exactly.
Okay.
Yeah.
So you might be seeing patients here and treating them here, but then doing procedures like that at another location. So,
exactly.
okay.
Yeah.
That is really neat.
Yeah.
I'm really surprised that, I really thought lung cancer, the low dose, would have been older than that. So when you said 2011, I'm thinking that is not that long ago.
No, it's not. It's really not. Lung cancer screening was so late to the game, unfortunately. But just like any other type of cancer, you implement the screening modality and you watch the graph and you see the numbers, and you just see, with mammograms and colonoscopies and PSAs and all these different things, you just see the impact. You can put it in a nice picture and just see the lines drop, and so we're seeing that now with lung cancer. It's been late to the game, and so much of it, and then this is another thing I suppose that we haven't really touched on, is so much of the barrier to screening with lung cancer is the stigma associated with smoking. There is a cultural stigma, and, to be honest, as a pulmonologist, so many of my patients smoke, and what you learn, and I remember being a kindergartner and making my parents an ashtray for Christmas, you know? I mean, like that, I remember that,
Sure,
right? So
sure.
that was, I mean, the culture is quite different now. Everybody smoked, back then, and you were in the service, you got your military fatigues, and you got a pack of smokes, right? I mean, it was so ingrained into certain cultures that there were so many people that did so for so long, and once you start, it is very, very hard to stop. It's very addictive, and so that stigma needs to be broken, and so the American Lung Association and other folks have really worked to put out ads and campaigns to really help promote lung cancer screening and really decrease that stigma. One of the commercials, very clever, showing images from the 1970s and, about everybody just kind of having those things, ashtrays around the house and, posters of doctors, saying, I smoke Camels, those types of things that just, were ingrained and embedded into our culture and society at that point. And decreasing the stigma. Take the stigma away. This needs to be something that is just like screening for any other cancer.
You're right. If we reduce that stigma, if we get people in to do this annual screening if they're at risk, we could be making a really big difference in people's lives.
Absolutely.
Dr. Mukherjee, thank you so much.
Absolutely. Thanks for having me.
We'd love to have you back again.
Absolutely. Love to be here. Thank you very much.